Good morning to all. So today our guest speaker is Brigadier Tathagata Chatterjee from Faridabad, Haryana. The topic is Flowcytometry and its interpretation in chronic lymphoproliferative disorder. It is supported by Mumbai Hematology Group. It is logistically supported by MCure and Perfect Square. So I want to thank Mr. Kevud Soni and team MCure, Mr. Yash, Mr. Kalpesh and the team Perfect Square, all the executive committee members of the MHG group. Today our chief guest is very eminent oncologist Dr. Lalit Mohan Sharma from Jaipur. Our guest speaker Brigadier Tathagata Chatterjee from Faridabad, Haryana. All our discussions were themselves eminent hematopathologists or flow cytometrists. All the participants for sparing your Sunday morning. Our discussions are Dr. Aditi Shah, Assistant Professor, Department of Hematology, KM Hospital, Parel, Mumbai. Dr. Akshaya, Consultant Hematopathologist, Suraksha Diagnostic, Calcutta. Dr. Amar Das Gupta, one of my teachers and a legend in this field, Director of Medical Services and Consultant Hematopathologist, Suburban Diagnostics, which is a big, very big chain of diagnostics in country. Dr. Amit Khurana, Consultant Hematologist and Bone Marrow Transplant Physicians from Surat. Dr. Amrita Saraf, Senior Consultant Department of Hematology, Sir Gangaram Hospital, New Delhi. Dr. Ankit, Consultant Hematologist and BMT Physician, Cure Hematology Oncology Clinic, Ahmedabad. Dr. Bijita, Hematologist from Department of Pathology from Maniktala, Calcutta. Dr. Deepak Charles, Consultant of Hemato-Oncology Stem Cell Transplant, Astor Med City, Kochi. Dr. Jyoti Bajaj, Assistant Professor in Oncopathology, Gujarat Cancer Research Institute, Ahmedabad. Dr. Kunal Sehgal, the Consultant Hematopathologist and Flow Cytometrist, Director, Sehgal Path Lab, Andheri, Mumbai. Dr. K. Gayatri, Hematopathologist, Lifeline Tapadia Diagnostic Center, Hyderabad. Dr. Muradharan, Super Specialty Medical Officer, CTC BMT Center, Borivali, Mumbai. Dr. Nadim, Consultant Medical Oncologist, American Oncology Institute, Jammu and Kashmir. Dr. Naveed Kakkar, Professor, Department of Pathology, Harship, Markandeshwar Medical College and Hospital, Solan, Himachal Pradesh. Prashant Sharma, Professor, Department of Hematology, PGI, Chandigarh. Dr. Prashant Bhatt, Hematologist, KMC Hospital, Mangaluru. Dr. Rama, Senior Resident, All India Institute of Medical Science, New Delhi. Dr. R. Manchanda, one of the very senior in this field in hematopathology in the country. Professor, Director of Pathology, KM Hospital, Pune. Dr. Rakhi Kar, Department of Pathology, Jipmar, Pondicherry, my previous institute. Dr. Rudhvi, Assistant Professor, Department of Transfusion Medicine and Immunohematology, Christian Medical College, Vellore. Dr. Seema Tyagi, Department of Hematology, Professor, AIMS, New Delhi. Dr. Sasi Bansal, Bhagavan Mahavir Cancer Hospital Research Center, Jaipur. Dr. Sindura, Staff Pathologist, Hematology, Department of Pathology, Kasturba Medical College and Hospital, Manipal. Dr. Tejashri, Majumdar Shah Medical Center, Senior Resident DNB Hematology, Narayana Health, Bengaluru. Dr. Tushar Sehgal, Assistant Professor of Lab Medicine, Hematology, AIMS, New Delhi. Dr. Udayan's Laboratory, Baroda, New Delhi, Gujarat. And today our guest speaker is Brigadier Tathagata Chatterjee. So he is DM from All India Institute of Medical Science, super annotated from Indian Army Medical Corps after 35 years of service to the nation. He's a senior consultant and head of hematology and IHBT, Professor Pathology, ESIC MCH Faridabad. Formerly, he was Chief Consultant Hematology and Pathology, Armed Forces Medical Services and Professor there. Head and Department of Pathology and Molecular Medicine, Army Hospital, RRR, New Delhi. Professor and Head of Hematology and Transfusion Medicine, AFMC, Pune. He is an alumni of AFMC, Pune and All Indian Institute of Medical Science, New Delhi, two very prestigious institutes in our country. He's the first DM hematopathologist in India and All India Institute of Medical Science from New Delhi. Research gets score 35, citations 1,100, H index 17, publication 166, written 23 chapters in textbook, including 5 chapters in Boyd's textbook of pathology. He was trained in molecular hematology and MRD from St. Jude's Children's Cancer Research Hospital, USA. Trained in oncopathology and cytopathology from TMH, Bombay. Trained in clinical hematology from All Indian Institute of Medical Science, New Delhi. Trained in flow cytometry from TMH, Bombay. And DM hematopathology from All Indian Institute of Medical Science, New Delhi. Our special guest is Dr. Lalit Mohan Sharma. So Dr. Sharma is a senior consultant medical and pediatric oncologist, in charge pediatric and preventive oncology, and assistant professor, Department of Medical Oncology at Mahatma Gandhi Hospital of Medical Sciences and Technology, Sitapura, Jaipur. After his MBBS, he obtained an MD in pediatrics from R&D Medical College, Udaipur. This was followed by a 3-year senior residency cum fellowship in clinical hematology from All India Institute of Medical Science, New Delhi. He then completed a 3-year fellowship in medical oncology and stem cell transplantation from the Tata Memorial Hospital in Mumbai. He worked at the Ratan Cancer Hospital in Kanpur from November 2003 to October 2006. He served as a senior consultant for 15 years in Department of Medical Oncology at Bhagavan Mahavir Cancer Hospital, Jaipur. Currently, he is based at Mahatma Gandhi Hospital of Medical Sciences and Technology, Sitapura, Jaipur. So I request Dr. Sharma to inaugurate the session and give some words of wisdom of your more than 15 years of practice. Thank you.
Thank you so much, Dr. Sanyal, for your kind words and excellent overview about the today's meeting. So with folded hand, respected teachers, my dear colleagues, my friends and young brigade, warm greetings from Pink City in Jaipur. And first of all, I'm thankful to Professor M.B. Agarwal, sir, who has been the pioneer force and having untiring efforts to make us much wiser and wiser on each weekdays, and to improve our understanding and knowledge about hematology, benign as well as malignant. He is master in creating an international network of science as well as the clinical progression. And we feel that this is necessary for incorporation of the recent updates and knowledge in our day-to-day hematology practice. It is always good that we learn the recent advances in the form of diagnostics, clinical approach, various molecular aspects of disease, and recent advances and treatment protocols based on the most available sophisticated evidence-based medicine. For all of us, now we can witness that the most recent scientific literature is just a click away. We can get whatever we wish in few seconds, in fact. Investigations, they are available from the basics, in fact, from the CBC bone marrow test to the highest end of molecular test. These are available to us nowadays, and majority of our recent treatment and the drugs are available for clinical use in India and other low middle income countries. If we see India as such, we are ahead of many low and middle income countries in the hematology as well as in the oncology. I can witness the quality of discussions, the quality of research being done, and on the top of that, the collaborative work at various private, government, as well as various other centers. And we can witness that various DNB, DM students, they are also a partner to whatever we are discussing in day-to-day life. Over the last 20 years of the clinical experience, I can see a grand change in the understanding as well as various workup and management of these complex hematological issues over the last 4 to 5 decades. Previously, even to diagnose the CML on peripheral smear was a big challenge in many cities, including Jaipur. Now I can see that the latest available investigations, they are accessible to most of us, and the network is so strong that even in remote areas, clinicians are able to do all the basic as well as the high-end investigations. Take example of CML. When I started my training, in fact, my senior colleagues will agree with that, that the average lifespan of CML patients was hardly 2.5 to 3 years. Hydroxyurea was the only drug available for most of us. And whenever we are seeing patient, we were feeling that this fellow's life is only for 2 to 3 years. Bone was a dream for majority of our patient. And now we can say with the better understanding of biology, as well as the availability of various tyrosine kinase inhibitors, we are able to put our 50% plus patients into treatment-free remission, and the disease is getting cured. So this is the power of science, as well as the modern diagnostic and therapeutics and the collaborative work which is available to all of us in our clinical practice. Take example of acute lymphoblastic leukemia. The survival was less than 25 to 30% many decades ago, and now we can see that it is more than 90% patients are surviving with available drugs. Pediatric oncology, if we see, it has not been a miraculous addition of various monoclonal antibodies or various immune checkpoint inhibitors, but the repositioning of the available drugs and understanding the biology with MRD, with the pre-induction phase, we are able to achieve these survival gains. Take example of thalassemia. During my training period, we were giving blood transfusion to majority of the patient and iron chelation. After the iron overload, most patients, they were hardly surviving beyond 2 decades of life. And now we can see the change, that we are able to do prenatal diagnosis, and now we are able to do prevention of thalassemia major childbirth in India, as well as in many various other parts of the globe. Anti-cancer drugs, if we see, including drugs being used in hematology, they are relatively cheap and affordable in India as compared to rest of the world. But still, I should confess that most of our patients, they are not able to afford even these the cheap drugs in India, and majority of our patients still do come from low and middle socioeconomic strata. We need to keep in mind whenever we are discussing the hardcore science, that we must think of a customized as well as some personalized approach for such patients, that the science, the whatever latest guidelines available, it doesn't suit each and every individual. We need to see the actual benefit of these drugs to the real needy patient. The modern medical science and practice has become more and more of lucrative, but again, we are paying a price also for that. So we need to find out certain ways to make these anti-cancer drugs as essential drugs, and we need to try to make them more affordable to our needy, underprivileged patient. Still, we are on the advancing age of hematology and many other diseases, including cancer. Still in India, we can see over last many decades, even after independence, more than 56% of are female of reproductive age, and close to 60% plus women lactating as well as pregnant women, and around 70% plus children with less than 5 years of young children are still having nutritional anemia. So we are going ahead and ahead of many recent advances, but still iron deficiency anemia remains one major problem to our country. We need to focus on these as well, that this is our responsibility. Government and every other efforts will be separate, in fact. So we need to make sure that whatever we discuss, our understanding about the science, biology, the medicine, the investigation, and the treatment, it should be able to reach to the common needy man, and it should be benefiting them. We all need to help these underprivileged society also. Like at my own place, Dr. Shashi Bansal knows that very well, that I am deeply involved in free service projects for needy patients and special attention to few diseases where we have high cure with less investment. So take example of chronic myeloid leukemia. Few years back, probably in December 2016, the Novartis, they stopped the GPAP program and new enrollments were stopped, in fact, and we were in trouble that what will happen to our new CML CP patients. What we tried at my center, we all had discussion and we started a similar project where we started to giving them the CML CP standard risk patient. We started free consultation, free CBC, free BCR-ABL, and free imatinib to these patients. And we were taking help from the hospital authorities to make the hospital services free. We were taking help from various NGOs so that we were getting some funds also. So we did not overload the hospital for the free schemes. And I'm proud to share that we have more than 270 patients enrolled in this project who were getting CML, who were getting imatinib and other supporting treatment free for these patients. So we all need to take that initiative. Take example of childhood acute lymphoblastic leukemia. We had opened another project called DALF, Donate a Life Foundation, where we were including 3 drugs: acute lymphoblastic leukemia, APML, and Hodgkin's lymphoma, because these are highly curable. The investment and the cost of therapy is less. So we were not compromising on the quality of treatment, and we were giving the patient the optimal treatment, in fact, in investigations. And we were able to raise funds, and we were able to support, and still the patients of more than 200 patients are getting support from these funds, and many of them are cured. So I think we all must try hard that the benefit of our discussion should reach to the most needy person into the remote areas. Ultimately, they are our brothers and sisters, and it becomes our huge responsibility to help the society, to help the community with modern science and whatever best we can do. So with these few words, I once again thank Professor M.B. Agrawal sir for giving me an opportunity to talk to you all vibrant and young friends. I thank Dr. Sanyal for kind words, and I thank Professor Tathagat Chatterjee for giving me an opportunity. Thank you so much.
Thank you, Dr. Sharma, for your kind words. So now we move up to the main important session, Brigadier Chatterjee. So please, Dr. Chatterjee, you can start.
Just a minute, I'll just. I hope my slides are visible and I'm audible.
Yeah, absolutely. It's fine.
Okay. Thank you so much, Dr. Sanyal, for that wonderful introduction. To our chief guest, Dr. Sharma, for the words of wisdom. Actually, he spoke so well, and he actually took us from the bed to the basics of hematology and to actually community hematology. So that was indeed a lovely piece of advice to all our young brigade. And of course, I thank Professor M.B. Agrawal, the doyen of hematology, for inviting me to the dais. Good morning, ladies and gentlemen. A big good morning to my teachers. To see Dr. Gayatri, Dr. Dasgupta in the dais is so fulfilling. So I'm going to speak on flow cytometric immunophenotyping in chronic lymphoproliferative disorders. Way back in 2008, I had started the flow in Army Hospital RNR. That time we had a 4-color Beckman-Coulter flow cytometer, which was lying in the department of immunology, actually, without much use. And it was just a serendipitous observation that there was an instrument which I could use. So I got it back to our department of pathology and we standardized it. And that's how my interest took place in flow cytometry. And we started doing lots of diagnostic work in that instrument, which came to us by chance from the Department of Immunology. So I bring you greetings from ESIC Medical College and Hospital, a central government hospital in Faridabad, which is a super specialty hospital with a 600-bedded strength. I superannuated almost a year and a half back, and I joined this college. We've got a big MD program, and we have got a transplant program too. And we have since done about 11 transplants, of which 7 were allogenic. So in this last 1.5 years, we have been able to also successfully install our 10-color 3-laser flow cytometer, and we have standardized not only a transplant program, but we have also standardized a lot of treatment of hematology from benign to the malignant aspects. And the flow cytometry has been in use for the last 1 year, and we have been able to do many cases. And maybe we have been able to mentor a lot of young doctors here. There are more than 300 doctors here, all willing to learn. And I am having a great time post-retirement mentoring youngsters. This is where it all began in Army Hospital Research and Referral, where I did my 3 tenures, and starting as a young specialist and graduating to become the head of the department. It was so much fun to be with so many youngsters whom I could mentor, and most of them are doing so well in the hematology aspects, both in the national as well as international networks. So I'm grateful to this hospital. And of course, where it all began, Armed Forces Medical College, where I joined way back in 1980. So with this in picture, I give you a brief idea of what I'm actually going to say in the next 1 hour. So I, of course, give a brief introduction, but I'll touch on what's new in WHO HEME5. Now, HEME5 is what is going to come out in 2022, the 5th edition of the WHO. What are the new things as is relevant to my topic today? I will only cover that and not more than that. Of course, whatever you do, whether you do flow, whether you do hematology, whether you do immunohistochemistry, whether you do oncology, you must have a great knowledge of the B and the T cell ontogeny, without which I think you should not come into the flow cytometry lab at all. So morphology and ontogeny and a basic idea is very important before you actually enter the instrument. The limitations of flow I shall discuss. Gating strategy, basics of gating strategy will be discussed. Technical aspects, limitations, and processing in brief. I will not touch that because that itself is a new topic by itself. Of course, I will end the chapter with the interesting case studies and give a take-home message. We all know that CLPDs are a heterogeneous group of malignant clonal proliferation of lymphocytes. And they are rightly classified as subtypes of non-Hodgkin's lymphoma and include disorders of the B, the T, and the NK cell lineages, all of which, of course, are further classified as distinct entities. Now, chronic B-cell lymphoproliferative disorders are much more common and in general have an indolent clinical course. As a pathologist or as a hematopathologist, we basically understand this group of disease by an immunophenotype that is similar to normal mature lymphoid cells. That is, the surface immunoglobulins on the mature B cells have to be expressed. Simultaneously, they will lack the antigenic features of immaturity, that is, expression of TDT and CD34. With this 2 important pictures in mind, we can actually diagnose the chronic lymphoproliferative disorders. Now, in the 4th revised edition of 2017, we had mature B cell neoplasm involving the blood, bone marrow, and lymphoid organs as CLPD, and a host of disorders were included in this, like the B cell CLL and SLL, the B cell pro-lymphocytic leukemia lymphoma, splenic marginal zone lymphoma, the hairy cell leukemia and its variant, the extranodal marginal zone lymphoma of MALT, the lymphoplasmacytic lymphoma, plasma cell myeloma, the leukemic phase of mantle cell lymphoma, and follicular lymphoma. And similarly, we had the T and the NK cell as the T cell large granular lymphocytic leukemia, the chronic variant of adult T cell leukemia lymphoma, the TCLL or the TPLL, and the chronic lymphoproliferative disorders of the NK cells. Now, the mature B cell neoplasm in the WHO proposed 2022, that is WHO HEME5 classification, has 12 families. And I'll just briefly cover the significant changes. Now, B pro-lymphocytic leukemia is no longer, repeat, no longer recognized as an entity. Why? It has a heterogeneous nature and is now maybe considered as a variant of a mantle cell lymphoma. Many of us actually thought that, are we dealing with a leukemic phase of a mantle cell lymphoma? And BPLL is now considered as a variant of a mantle cell lymphoma. A PLL progression of a CLL and SLL, but PLL coming from CLL unlikely. So a CLL with increased PLL cells and a PLL progression of CLL to SLL, okay, that may be considered. And a new category called the splenic B-cell lymphoma leukemia with prominent nucleoli. During the course of the discussion, you will see that this entity has replaced the hairy cell leukemia variant. Now we call it splenic B-cell lymphoma leukemia with prominent nucleoli. The monoclonal B-cell lymphocytosis, MBL, has now 3 categories. So we have a new category called the low count MBL. Then we have the CLL, SLL type of MBL, and we have the non-CLL, SLL type of MBL. They have also categorized what should be the essential and what should be the additional marker of flow cytometry immunophenotyping in CLL. They say CD5, CD19, CD20, CD23, surface or cytoplasmic kappa and lambda light chains are essential. Now, this is a very important statement. Surface or cytoplasmic kappa. Many times, your surface kappa or lambda restrictions cannot be done on the flow. In that case, you do the cytoplasm. So they have included both surface or cytoplasmic kappa and light chain changes as an essential IPT for flow in CLL. In the additional one, they have used CD200, and we know the value of CD200. We will discuss that subsequently. CD43, CD10, CD79B, and CD81. Obviously, you will get negativity in CD10 because it is a post-germinal center, CLL, and not a germinal center. So the negativity of CD10, the intensity of CD79B will be studied, and a new marker called the ROR1, which is a TCR receptor factor, is now being added as an additional factor in the flow in CLL. Now, splenic B-cell lymphoma leukemia with prominent nucleoli replaces, as I said, hairy cell leukemia variant and the CD5 negative DPLL. Regarding the lymphoplasmacytic lymphoma, IgM matters. So you have two molecular subsets of IgM LPL or Waldenstrom's based on the presence or the absence of the MYD88PL265P mutation. So majority will have this mutation, but some will not have. So you have two groups. The pediatric nodal marginal zone lymphoma is now a separate entity along with primary cutaneous marginal zone lymphoma. The follicular lymphoma is now classified as classical, a follicular lymphoma, B lymphoma, and an unusual follicular lymphoma. The grading in classical follicular lymphoma is now no longer mandatory. The mantle cell lymphoma comes with improved risk stratification. Similarly, a few nomenclature changes in the T and the NK cell lymphoid proliferations and lymphomas in the WHO HEM5 has been added. So we no longer call angioimmunoblastic T cell lymphoma. What do we call it? We call it nodal T follicular helper cell lymphoma, angioimmunoblastic type. So this is a change in the nomenclature. Similarly, nodal TFH cell lymphoma follicular type is the preferred term rather than follicular T cell lymphoma. Nodal TFH cell lymphoma, not otherwise specified, is the term used rather than nodal peripheral T cell lymphoma with TFH phenotype, which was the entity in the revised WHO 2017 4th edition classification. NK large granular lymphocytic leukemia has replaced chronic lymphoproliferative disorder. And a new entity called Epstein-Barr virus positive nodal T and NK cell lymphoma has been added. This was not there in the previous WHO HEM 4th revision. So with this few words about what's new in WHO 2022, let's go to our main topic, flow in mature lymphomas. We all know that flow has a well-established role in the diagnostic evaluation of mature lymphomas. Its role is in effective lineage assessment, aberrant antigen expression, and immunoglobulin light chain restriction. So these are the three important roles. Limitations must always be appreciated with regards to the gold standard morphology, along with immunohistochemistry, cytogenetics, and molecular testing. So the two most basic roles the flow answers is assignment of lineage and distinction between neoplastic and non-neoplastic B and T cells. Now, if you see our ontogeny, this is the motherboard to anything in hematology. The bone marrow has the progenitor B cell, the pre-B cell. Now, the pre-B cell has a cytoplasmic mu heavy chain. Once it becomes an immature B cell, the light chain comes along with the cytoplasmic immature strain. And here, this immature cell can either go and undergo apoptosis or form the naive B cell. The naive B cell has got two roles. It can go into the mantle in the primordial follicle of the lymph node as resting lymphocytes. And the naive B cell on antigenic stimulation forms an extracellular B blast, which can form short-lived plasma cells. This extracellular B blast, which is an antigen-stimulated naive B cell, is having a surface IgM. And this is the cell which can either go to the germinal center or go bypass the center and become the memory B cell. The CLL cell originates either from the memory B cells, which you will see subsequently are mutated in the immunoglobulin heavy chain gene, or it can form from the naive B cell after antigenic stimulation. Also, CLL cells can come from the cells which have entered, become the centroblasts, become the centrocytes, and become the memory B cells, both of which have got IgM. So this is very important to know. The centroblasts have to undergo apoptosis. So they lose their BCL2 and they gain CD10 and BCL6 and become the centrocytes. The centrocytes thereafter become the long-lived plasma cells. So this in nutshell is an overview of the ontogeny. So in this case here, the interfollicular area will give rise to mantle cell lymphoma. The germinal center areas will give rise to follicular lymphoma, Burkitt lymphoma, some cases of DLBCL germinal center type, and of course, Hodgkin's lymphoma. And the post-germinal center neoplasms will give marginal zone and Malt lymphomas, the lymphoplasmacytic lymphomas, the CLL, SLL, and the activated B cell type of DLBCL and the plasma cell myeloma. You will see here the CD10 will be negative, unlike the ones which are coming out of the germinal center, in the germinal center rather, which are CD10 positive. So your ontogeny and your surface markers and your cytoplasmic markers are all based on your knowledge of this particular slide. So B cell neoplasm corresponds to various stages of normal B cell maturation. The precursor B cells in bone marrow develop into the mature naive B cells, which develop into either a short-lived plasma cell or, as I said, enter the germinal center where somatic hypermutation. The two important things takes place in the germinal center: somatic hypermutation and heavy chain class switching. The moment you have these two items, you know these are from the germinal center. The centroblasts will undergo apoptosis and develop into centrocytes. The post-germinal center cells will include both the long-lived plasma cells and the memory marginal zone cells. Accordingly, the precursor B cell neoplasm will be lymphoblastic lymphoma. The pre-germinal center will be mantle cell. The germinal center will be follicular lymphoma, Burkitt's, DLBCL, germinal center type, and Hodgkin's. And the post-germinal center neoplasm will give rise to a CLL, SLL, DLBCL, plasma cell myeloma, MALT, LPL, and the marginal zone lymphoma. This further categorizes the B cell ontogeny. So in the interfollicular area, follicular area, perifollicular area, and the peripheral blood and external tissues, you have the various types of mature lymphomas. And accordingly, we have an issue whether the cells were foreign antigen independent, they were foreign antigen dependent, or they were terminally differentiated. So all the terminally differentiated cells form the myeloma and the plasmacytomas, and the foreign antigen dependent cells is what we are going to discuss today. They form the BCLL, the mantle cell lymphoma, the follicular, and accordingly we have the markers. Remember, the CLL will have a CD10 negativity because it is a post-germinal center cells. Similarly, you have CD79A, BSAP, and BCL6 in cases of Burkitt's lymphoma, follicular lymphoma, LPH. So once you have a good knowledge of ontogeny, you can have a fairly good knowledge of what markers are likely to be positive and what markers you're going to include in your flow cytometry panel. So the naive B cells are CD5 positive. These are the small resting lymphocytes in the peripheral blood, and they are BCL6 negative. Now you can understand why the naive B cells are BCL6 negative, because they have not entered the germinal center. The germinal center centroblast, the BCL2 is switched off. So centroblast is always BCL2 negative. They acquire a CD10 and they become BCL6 positive. The BCL6 negativity in the memory B cells and plasma cells are also an issue. The moment BCL6 becomes negative, an important marker called IRF4 M1, MUM1 becomes positive. So similarly, the post-germinal center cells, particularly the plasma cells, are IRF4 MUM1 positive and BCL6 negative. Centrocytes. The centrocytes will always express surface membrane immunoglobulin and BCL2, but are generally BCL6 negative. So again, BCL6 and IRF4 are reciprocally expressed, with IRF4 positive in plasma cells and simultaneous downregulation of BCL6. Therefore, a plasma cell will lack surface membrane immunoglobulin and CD20, but will express IRF4, CD79A, CD38, and CD138. Now, CD138 is exclusively expressed in the plasma cells, whereas in the myeloma cells, whereas CD38 will be on plasma cells as well as in activated myeloid cells. Similarly, the antigen-specific T cells mature in the thymic cortex. The cortical thymocytes are the primitive cells. They express TDT and CD1A along with the pan-T markers of CD3, CD5, and CD7, and they are double negative. Now, these are important terms to understand before you go to the flow. The cortical thymocytes are double negative for CD4 and CD8. Thereafter, once it matures, it becomes medullary thymocytes. So they express the mature T cell markers, and they are either CD4 positive or CD8 positive. So, for example, a Sézary cell will be CD4 positive, CD8 negative. Coming to the NK cells, they are negative for surface CD3 because they do not form part of the entire part of the T cell receptors. So the natural killer cells will express 2, 7, 16, and 56, but they will be negative for surface CD3. And these are the hallmarks of how to go to the flow and experience and interpret the IPT. The gamma delta T cells will lack all the 4s and the 8 and the 5s, and they will express the gamma delta of the T cell receptors. Now the CD4 helper cells are divided into a Th1 cell and Th2. These are also so very important in flow cytometry. The Th1 cells normally secrete interleukin-2 and interferon gamma. And what do? They provide help to other T cells and macrophages. Similarly, the Th2 cells will secrete interleukin-4, 5, 6, and 10, and they provide help to the B cells in production of antibodies. Another CD4 effector T cell is the Th17 cell. They secrete interleukin-17. The host defense at mucosal and epithelial barriers are controlled by Th17. What is the importance of T follicle helper cells? As you see in various types of lymphoma, these cells help the B cells in the context of germinal center reaction. Some of the important markers of TFH cells are BCL6 and CD10 and CD4 and CD57, which are readily available with us. In addition, we have a PD1 or a CD279 expression along with CXCR5. Now, these T follicular cells, as in angioimmunoblastic T cell lymphoma, you have to have a minimum of 2 expression of T follicle helper cells to categorize the cell as diagnosis of angiofollicular helper immunoblastic lymphoma. So with this background, we go to the flow. So what do? We identify the B cell lineage. To identify the B cell lineage, we use a panel. And which is that panel? CD19, CD20, CD22, and CD79. What is CD19? Most useful. It is lineage specific. It is reliably expressed in immature and mature B cell lineage alike. All mature B cell neoplasms express CD19. But who are they which do not express CD19? Plasma cell myeloma, plasmablastic lymphoma, and primary effusion lymphoma. What about CD20 and CD10? The positivity of 20 and 10 evaluates the maturity pattern in the bone. So a decreased or absent CD20 is seen in CLL, SLL, and large B cell lymphoma. So the intensity of your expression as well as percentage positivity are both very important to interpret when you're doing the CLPD panel. Now CD22, this is variable, but the brightest expression of CD22 is seen in hairy cell leukemia. We'll discuss that in a case. So given this variable expression of neoplastic B cells, what the Flow Cytometry Society recommends is use at least 2 markers for lineage. First, identify all the B cells in the specimen, that is the NDCE or non-debris cellular elements. Identify all the B cells in the specimen prior to additional gating and use at least 2 markers for lineage specificity. Care must be taken for abnormal B cells with high side scatter or high forward scatter or non-viable cells. High-grade lymphomas are sometimes comes in this category and creates a lot of problems in our interpretation. Of course, the issues of antibodies and fluorochrome selection, the panel construction, the antibody titration, instrument setup, analysis, and interpretations are all critical steps. And the specialist of the flow instruments, along with you, you all should sit down together and sort out these issues. The second aspect is distinguishing reactive and neoplastic mature B cells. Very easier said than done. First, identify all the B cells, as I said, with lineage associated marker. Thereafter, consider the stage of maturation. So a mature B cell lymphoma will have a high expression of CD45. However, As I said earlier, few high-grade lymphomas may have decreased CD45. So you should keep that in mind. CD10 and CD38, these are expressed in both immature and mature B cells. So how do you solve the issue? Take a CD34 and TDT. If they are positive, you're dealing with immature cells. Surface hemoglobin is the hallmark. It is expressed in most mature B cell neoplasms. And as you all know, any normal or reactive sample must have a mixture of a kappa lambda light chain ratio 1:1 to 2:1. This also can be analyzed. So mature B cell neoplasms are clonal with a immunoglobulin single kappa or a lambda. However, there are times when the monotypic B cells are obscured by polytypic B cells. So always in such cases, check for light chains ratio skewed towards either kappa or lambda. Which of this is higher? Such cases are seen in follicular lymphomas. So be very careful when you do the flow in follicular lymphomas. Sometimes your monotypic B cells may be obscured by the polytypic B cells. Also in such cases, when you're not getting an answer of immunoglobulin single kappa or lambda, it is important for evaluation of abnormal antigen pattern, and that itself can help you in establishing clonality. Now, not all mature B cell neoplasms express surface immunoglobulin. For example, CLL, SLL, and mind you, surface immunoglobulin is used in the scoring, the matute scoring of CLL, SLL. But sometimes surface immunoglobulin may not be expressed at all. A subset of follicular lymphoma and large B cell lymphoma also may be surface immunoglobulin negative. So you have to keep that in mind. And a subset of follicular hyperplasia with CD10 positive cells may lack kappa or lambda. So these are some of the twists in the tail which you should be aware of. Monotypic light expression, as I said, is not the only indicator of B cell clonality. So here, aberrant pattern of antigen expression or other lineage expression may give you the clue. So the flow data should always be interpreted in context, and this I repeat, in context of morphology and clinical features, and not in isolation. Lack of abnormal B cell population by flow, ladies and gentlemen, does not exclude B cell neoplasm due to issues in sampling. So detection of monotypic B cell population, sometimes not indicative of B cell neoplasm, is seen in situ follicular lymphoma, monoclonal B cell lymphocytosis, and some reactive processes. With this in mind, we now come to the role of flow in refining diagnosis and prognosis. So after you have established the diagnosis, now the flow will help you in sub-classification. So we essentially focus on three groups. A CD5 positive, small B cell neoplasm, a CD5 negative.
Video audio off.
Please mute. A CD5 positive small B cell neoplasm, a CD5 negative, CD10 negative small B cell neoplasm, and a large cell neoplasm and high-grade lymphoma. So what are the CD5 positive small B cell neoplasm? The main differentials are CLL, SLL, mantle cell lymphoma, and marginal zone lymphoma. Now the characteristic immunophenotypic features of CLL, SLL will include a dim CD20, a moderate intensity to bright CD23. Now this is important, dim CD79B, dim or negative FMC7, and a dim surface membrane immunoglobulin expression. These days in tissue diagnosis, we have a marker called LEF1, which is overexpressed with poor prognosis. No mature B cells or any lymphoma, to my best of my knowledge, expresses LEF1. So if you have some doubt, you can go back to the IHC, and if you've got this LEF1 marker and if it is positive, surely you're dealing with CLL. Classical mantle cell will express bright CD20, will lack CD23, and will show a bright expression, unlike CLL will show negative or dim expression. Here you will have a bright CD79B and a bright FMC7 and a bright surface membrane immunoglobulin. But the phenotype may be quite variable. SOX11, as you all know, is a very, very specific marker for mantle cell lymphoma. So sometimes if you are having a problem between CLL and mantle cell, which you should not have generally, you can do the SOX in tissue and find it whether it is mantle or not. Now, CD200 is of diagnostic value in a CD5 positive small B cell neoplasm, being highly expressed in CLL, SLL, and having a high sensitivity and specificity for the distinction between CLL and mantle cell lymphoma. However, please note, 4% of mantle cell lymphoma express CD200. And this appears to correlate with lack of SOX11. Now, SOX11 is a specific marker for mantle cell. If 4% of mantle cells express CD200, they don't express SOX11. And these are the cases which have an indolent clinical course with a hypermutated IGVH gene. We all know the CLL scoring system of Matutes et al. Incorporating now CD200. Why? To increase the specificity for diagnosing CLL. A new scoring system, some of you might have used it, is the Kohenke et al. Scoring system, which we call the CLL flow score, with a formula based on the percentage of B cells with specific phenotypes. So here we do the percentage of CD200 positive cells plus percentage of the ratio of the CD23 to CD5 positive cells and subtract this from the percentage of CD79B positive and the percentage of FMC7 positive. A score greater than 0 is consistent with CLL. This formula is important because it has demonstrated a sensitivity and specificity of 97.1% and 87.2% respectively. I have not yet used it. I am still using the CD200 modified Matute scoring. Now, cyclin D1 can also be assessed by flow. While assessment of cyclin D1 expression by flow has been reported, it is, remember, technically very challenging and appears truly less informative than immunohistochemistry. So if you follow what I'm trying to tell you is, if you have an issue of cyclin D1, IHC is the answer and not flow. SOX11 detection by flow in mantle cell lymphoma appears promising, has been reported. I have got limited experience. Now, CD5 positive small B cell neoplasm is used for prognostication of CLL. Over the years, most of the labs, and you all know about it, the CD38 and ZAP70 expressions were used as potential surrogate marker for IGVH mutational status. Cases expressing 38 and ZAP70 correlated with the unmutated IGVH genes and unfavorable prognosis. However, you all know that evaluation of these markers has not become standard, and most laboratories do not even offer them. Perhaps due to variability in the accepted cutoffs, lack of standardization, and now the identification of other molecular characteristics which makes wise therapeutic decision, namely TP53 deletions and mutations. Subsequently, and this is a new one for you, a surface CD49D expression in the flow has now been shown to be superior to 38 and 70 in identifying ZAP70 and identifying CLL patients with an unfavorable prognosis. Indeed, CD49D has been found to be one of the most important independent prognostic factors in a large series of CLL patients, which also included the IGVH mutational status and TP53. Now coming to the CD5 negative, CD10 negative small B cell neoplasms. In the diagnosis and subclassifications of small B cell lymphoma disorders, the detection of a monotypic CD5 negative, 10 negative B cell population by flow poses a diagnostic channel. And what are the considerations we include in this? The hairy cell leukemia, the hairy cell variant, the lymphoplasmacytic lymphomas, and the SMZL and the SDRPL, that is clinic diffuse red bulb lymphoma. Expression of CD25, a bright CD11C, a bright CD22, CD103 and CD123 in the correct morphologic and clinical context will allow confident diagnosis of hairy cell leukemia. SMZL lacks most of the hairy cell leukemia markers, but remember, it may be weakly positive for CD103. Flow can assist in the distinction between lymphoplasmacytic lymphoma and plasma cell myeloma. The most useful distinguishing features are expression of CD19 and CD45 by the lymphoma, and hence the importance of using CD45 in your CLPD panel, and the lack of expression by plasma cell myeloma, with expression of CD56 by most plasma cell neoplasms, and lack of the same by lymphoma. So 45 positive, 19 positive, and 56 negative is the LPL, vis-a-vis a 45 negative, 19 negative, and a 56 positivity, which is a plasma cell myeloma. The last aspect of this is the B cell neoplasm of larger cells, including high-grade B cell lymphoma. Here, I do not know how much you will agree with me, but flow cytometry is of less value in the diagnosis and classification of the high-grade B cell lymphomas than it is for the small B cell neoplasm. The assessment of the forward light scatter by flow can be helpful in estimating relative cell size, especially in disaggregated cytology specimens. However, the flow in high-grade lymphoma is useful. Why? It documents the presence of a B cell clone. It excludes the possibility of lymphoblastic leukemia and lymphoma. It distinguishes plasmablastic lymphoma and primary effusion lymphoma from the plasma cell myeloma. And finally, it determines the relationship to a previously diagnosed lower grade lymphoma. For diagnosing lymphoblastic lymphoma, the helpful features pointing to a blast population includes the presence of immature markers like CD34 and TTT and decreased expression of CD45 and CD20. There is currently only a limited role of flow in the workup of diffuse aggressive B-cell lymphoma, with the emphasis falling more on morphology, immunohistochemistry, and cytogenetic studies. Coming to the mature T and NK cell lymphoid neoplasms, we'll answer the various questions. Are the neoplastic cells T or NK? Flow is superior to IHC. Why? Flow detects fully assembled TCR CD3 complex. This is absent in NK. IHC will detect only the epsilon component of the CD3 and therefore does not distinguish the T from the NK. Second question, is there expression of CD4 or CD8? Flow has the advantage of readily identifying neoplastic cells through aberrant expression of other antigens. So suppose you don't have a T cell alpha or a receptor analysis with you, aberrant expression of antigens and expression of 4 and 8 and its ratio will give you a clue to the clonality. IHC cannot differentiate a reactive T in an admixed neoplastic cell. Third question, is there expression of NK cells like 16, 56, 57? Here, flow is much more sensitive than IHC. In fact, ladies and gentlemen, IHC for CT16 is not even available. Is there expression of T cell receptor and its alpha, beta, or gamma delta component? FCM is the optimal method here. Gamma delta IHC is not available. Do the cells express TIA, cytotoxic T cells, granzyme B or perforin? FCM is optimal. Do neoplastic cells express CD103? Now, this is a subset of intramucosal T cell and AITL, which are positive for CD103, and here FCM is optimal. However, IHC is superior in Epstein-Barr virus detection. CD30 ALCON for anaplastic large cell lymphoma, IHC holds the key. So a big overview of the mature T cell neoplasm, a 4 positive, 8 negative. What are the conditions? Cutaneous T cell lymphoma, TPLL, ATLL, ALCL, AITCL, and peripheral T cell lymphoma. 4 negative, 8 positive, you're dealing with TLGL, and a CD8 positive peripheral T cell lymphoma unclassified. Both 4 positive and 8 positive unusual in mature T cell lymphoma. Maybe you are dealing with a TALL or a TPLL. Mature NK cell neoplasm, it is important to distinguish these aggressive neoplasms from the indolent LGL. The indolent NK cell LGL are 57 positive, 56 positive, but Epstein-Barr virus always negative. The extranodal T NK cell neoplasm of the nasal type will be 56 positive, Epstein-Barr virus positive, and TIA1 positive. A quick look at the plasma cell disorders. Flow is a useful tool and you must include your plasma cell markers in your CLPD panel. This helps to identify abnormal plasma cells and differentiate it from lymphoid neoplasms. It also gives you prognostic assessment. Normal plasma cells are bright CD38 positive. The CD138 is restricted to plasma cells only. CD38 expression, however, is also noted in hematogones, mature B cells, activated T cells, as well as myeloid cells, but at a much lower intensity. So evaluating both 38 and 138 is of paramount importance. The neoplastic plasma cells are 19 negative, 20 negative, 45 negative, 38 to 138 low intensity compared to the normal plasma cells where the 38 is extremely bright. Now to get both CD19 and 20 positive in a neoplastic plasma cell is a rarity. Bone marrow plasma cells, mature cells are 19 positive, 20 negative. So neoplastic plasma cells will express CD56 aberrant expression. They are 27 negative, 28 positive, and 117 positive in 20% cases. So you should use your 117 in plasma cell disorders. A plasma cell leukemia is CD56 universally negative. However, what is the limitation of flow? It identifies fewer plasma cells compared to IHC. MGUS can be diagnosed by flow when significant amount of two populations of a normal plasma cells mixed with neoplastic plasma cells can be identified. Prognostication by flow is consistent, where the CD28 positive has shown reduced event-free survival. A 27 negative, 45 negative has shown adverse prognosis, and a S phase fraction has strongest independent predictor for survival. With this, we come to the next portion of a case, approach to a case of CLPD. Now, way back in 2008, Tata Memorial Hospital had come up with the national guidelines, which was published in the IJPM. So they used 8 antibodies, 5, 19, 23, 10, 20, FMC7, kappa, lambda. These are robust antibodies, and it could answer most of the questions of CLPD. And this is the basic minimal panel, which should be employed by labs which have got problems in procuring too many antibodies. So this basic panel still hold goods. They also added a T cell panel in case the issue was of CD19 negative. Then you are suspecting a TNK plasma, so you put a T cell panel. Otherwise, this was a flow diagram. A 19 positive, 5 positive, 23 positive, FMC7 negative or CLL. A 19 positive, 5 positive, 23 negative, FMC7 positive with a cyclin D1 positive on IHC was mantle cell. And a 5 negative with a 10 positive was follicular lymphoma, DLBCL or Burkitt's. And a 5 negative, 10 negative with a 25 and 103 positive was hairy cell leukemia. And others included SMZL and DLBCL. The principles of antibody panel design is the goal. Maximize information obtained per unit of specimen, unit of cytometry staff, and the unit of cytometry time. You have to see all aspects of cytometry where you are the manager. Maintain across tube compatibility. For example, you can put the CD45 side scatter gating in all your tubes while minimizing antibody redundancy. You must pair strongly expressed antigens, example, neutrophil CD16 markers, with dimmer fluorochromes, example, FITC or Alexa 700 and vice versa. You must combine antibodies to maximize the ability to identify abnormal cell population. Example, you can pair CD34 and CD7 antibodies to look at blasts. All things being equal, choose immunoglobulin G1 over G2 antibodies, and these are references by Wood, BL, 11GR cytometry, clinical cytometry of 2006. Way back in 2008, as I said, we used these fluorochromes and monoclonal antibodies in lymphomas in our 3-color panel. So we had a FITC, PE, PETR, and a PE-Cy5, and we use various antibodies, and this could answer most of the question, and this helped us to answer the questions which was proposed by the Tata Memorial Hospital in the minimal panel, and we employed the minimal panel, and we could answer most of the CLPD panels in the early 2000s. However, now we have this 21 antigen viability dye in our institute, and we have a violet, blue, and a red laser, and we have various antibody panels. We use CD45 in all our tubes, and this is a 21 antigen panel along with viability dyes. So why use a 10-color flow? You can use a 4-color flow or 6-color flow. So the important is of getting that many information in the form of dot plots. So when you get information from small samples in FNA or CSF, you use the 10-color, which yields much more information. So the statistics shows 7.5 times more information than 4-color flow. Here you have a 45 dot plots vis-a-vis the 6 dot plots of a 4-color. When you're using a 6-color flow, it has got a 15 dot plot vis-a-vis a 45 dot plot of a 10-color. And when you're using an 8-color flow, you've got a 28 dot plot. We can routinely collect 1 lakh viable cells. For MRD, 3 lakh viable cells are able to identify even small abnormal populations which could be missed by a lesser color flow. And even in small biopsies which you can process for flow, one can almost always make definitive 2008 WHO diagnosis when combining flow with histology and limited IHC fish. Streamlining of specimen setup and reporting of lesser with faster turnaround time is also possible with a 10-color flow. Now, this is the basics for the young brigade, as our chief guest put it. For a gating strategy, for B cells, you have the CD19 side scatter. For the T cells, you have the CD3 side scatter. For viable cells, you have a CD45 side scatter. For blast, you will have CD34 side scatter. The lymphocytic gate will have a bright CD45 and a low side scatter. Here, the benign lymphocytes and the mature LPDs will come. The monocytic gate will have a bright CD45 and a higher side scatter. Here you'll get cases of CML, AML, hairy cell leukemia, and MDS. Hematogon's gate show low side scatter and dimmer expression of CD45. A blast gate will show moderate CD45 and a high side scatter. Plasmacytic gate will have a 45 negative with an increased forward scatter and a low side scatter. So B lymphoblastic lymphoma, AML, CLL, and a TPLL can come in this gate. You also have a metastatic gate, which is 45 negative. Plasma cell neoplasms and erythroid precursors can come in this gate. And of course, the granulocytic gate with a moderate 45 positive and increased SSC can be seen, of course, in APML, mast cells, and AML. Problems. Non-specific binding of antibody to sticky cells. This is universally faced by all of us. And the apparent lack of staining of the surface immunoglobulin. Now, to avoid false negative results, include an initial watch step for flow cytometry tubes containing anti-immunoglobulin antibody, since the soluble antibodies interferes with binding of detection antibodies. Follicular lymphomas may lack surface immunoglobulins. The problems can be overcome by trying different clones of monoclonal antibodies or identify a co-expression of the cytoplasmic BCL2 and CD10. Some of the lymphomas lacking surface membrane immunoglobulin would be ALL, plasma cell neoplasm, primary mirational B-cell lymphomas, and the CLL. Aberrant expression, myeloid antigens in LPL. This can also take place. BCL2 expression on a CD10 positive cells in follicular lymphoma, DLBCL, and BLL can be a problem. Alterations in intensity of staining of B lineage associated antigen. For example, decreased intensity of CD19 with increased intensity of CD10 in follicular lymphoma. This will help you in distinguishing from normal follicular cells. So all these have to be kept in mind through experience. A significance of small population of phenotypic abnormal B cells like CLL-like population in old age is seen frequently. And please do not label such cases as CLL. This you will see in old age. False negative flow, evaluation as in sampling error, cell loss during processing, paucity of neoplastic cells, and difficulties in identifying cell populations have all to be kept in mind. The role of flow in therapeutic decision-making for mature B-cell neoplasm is now very much there. Potential therapeutic options include monoclonal antibodies directed against B-cell associated antigens like CD20, CD22, CD79B. Flow also provides a useful tool for detecting residual disease following therapy with assays designed for the purpose. For example, for MRD and CLL, you use a combination of 3 tubes. In the first tube, you have the 5, 20, 38. In the second tube, you have the 5, 22, 81. In the third tube, you have the 5, 43, 79B. These are all recommendations by the international working groups. So we had a national lymphoma workshop in Army Hospital RNR way back in 2019, just before the COVID hit us. And this was attended by more than 150 participants. And we discussed the flow of lymphomas, the flow of fluids. So if any of you are interested in getting the soft copy, do mail me and I will mail you the soft copies. We will not discuss the sample processing, this myelination of tissue and all for paucity of time. And we will now come to our case studies. So with this in background, let us approach our cases. The first case is a 30-year-old male who has presented with non-specific musculoskeletal pain for past 1 year. This patient is still there with me. I had diagnosed him in 2009. He was incidentally detected to have lymphocytosis during evaluation at a tertiary care hospital. There is no history of fever, weight loss, or night sweats, no peripheral or central lymphadenopathy or organomegaly, no previous history of any illness in the past, and he sustained injury to the back while on duty, incidentally. This was the hemogram. The TLC was 5,000, lymphocytes were 64%, rest were normal, LDH was okay. The bone marrow aspirate showed a cellular spear with normal marrow components with prominence of mature lymphoid elements. The biopsy was cellular with prominence of lymphoid elements, no lymphoma cells. We did not get any specific pattern except a vague interstitial pattern of lymphoid cell sprinkling in the bone marrow. The flow analysis, the grading strategy was site scatter 19. 4.5% of all viable cells are monoclonal B cells. They expressed moderate CD19, moderate CD20, moderate CD22, moderate FMC7, dim CD5, bright CD45, kappa restriction, and a bright surface membrane immunoglobulin. The CD19 and kappa co-expression was seen in 96% of the gated population. They were negative for lambda, CD23 and 10. Number of CD45 positive monoclonal B cells is very low. CD3, 4, and 8 are all negative. They are negative for 34, 103, 11C, 16, 56. So this was a case of monoclonal B cell lymphocytosis, where MBL is an asymptomatic precursor condition for CLL. This has now been redefined in the WHO 2022 classification. This is defined by presence of small clones of aberrant B cells in the peripheral blood with a total B cell count below the threshold for the diagnosis of CLL. It occurs in 4 to 5% of healthy adults. Most cases of CLL are preceded by MBL, in fact, all cases. However, only 1% of MBL will progress to CLL per year requiring treatment. The absolute B cell count is most strongly associated with progression. These days in WHO 22, we have got a low count MBL, which rarely progresses. And this was the case in our patient. He has still not progressed and he's doing well. Patients with clinical MBL should be monitored annually for progressive lymphocytosis and signs and symptoms of CLL. Now, what is CLL and atypical CLL? We keep getting these questions often on. Normal CLL is positive for CD19. There's a dim surface IgM and D. CD20 is dim, CD22 is dim, and CD79B is dim. They are positive for CD5 and CD43. They are strongly positive. Now we'll see what is strong in strongly positive for CD200 and CD23. They are CD10 negative and FMC7 is usually negative. So a modified scoring system has been integrated to help in the DDs of CLL. The scoring proposed in the modified score has been the basis of diagnosis of the past 15 years and is defined by strong expression of 5 and 23 with a low or absent expression of 79P, IgM, and FMC7. The Matute Katofsky score of 4 to 5 gives you CLL. Anything below 4 is non-CLL. Now the modified Matute score incorporates CD200. So positivity is seen in more than 30% of positive cell population. So CD5 and 23 are counted as score 1. FMC7 and CD9B are dim. So they are considered score 1 when the positive cells or populations are less than 30%. Additionally, surface membrane immunoglobulin is considered score 1 when the expression was weak. And sometimes the SIGM is not positive, then you have to go for a surface, for a cytoplasmic state. Typically, a CLL case will be defined by a score of greater than 4 and an atypical case by a score of less than 4. The CD200 intensity is estimated by the median fluorescent intensity ratio of the MFI of the sample of the MFI of the isotope ratio. And this has now been incorporated in the modified Matute. So this is a flow of SLL CLL where we are seeing a bright CD45 positive and it is showing a small lymphocytic cells in the 45 bright gating strata. Here there is a 19-5 co-expression and there's also 23 positivity along with 20 positivity and the kappa is restricted. And here we see the FMC7 is negative as well as the lambda is negative. We did the CD38, which was positive, and those days we were doing a ZAP70, which was not very well standardized. So now the newer scoring system has increased the specificity of CLL. A ratio of CD5 to 23, FMC7, 79B dim, and CD200, as I said, has been proposed in the new scoring with high sensitivity and specificity. Now coming to the atypical CLL, these are generally CD5 negative or CD23 negative. FMC7 is strong positive. There is a strong surface membrane immunoglobulin, or even CD79B is strong. Normally you expect it to be dim. So here, before you diagnose this as atypical CLL, we must exclude the CD5 negative SMZL before considering it as an atypical CLL. And as I said earlier, in difficult situation, go for LEF1 in tissue sections. All B-cell lymphomas as well as mature lymphocytes are negative for LEF1. The only condition where LEF1 is positive is CLL. Such cases, as I said earlier, will be SOX11 negative. So SOX11 positivity further qualifies it as mantle cell. Thereafter, you can go for FISH for a deletion 13q 14.3 or a IGHV mutations to confirm CLL. A third case is a 65 male with cervical and axillary lymphadenopathy with fever on and off for 2 months. Hepatosplenomegaly is present with cervical and axillary lymphadenopathy. Here, there is 73% lymphocytes in a TLC of 23,000. The flow cytometric analysis show a bright 19 positive with a low site scatter. This is 19 positive and 5 positive. The 23 is negative and the kappa is restricted. Lambda is negative. SMIC is strongly positive. You see SMIC is a strongly positive. FMC7 is positive and CD22 is also variable expression. 103 is negative, 11C is negative. So these are the positives 5, 19, 20, SMIG, FMC 743, and the negatives of 10, 23, 200, 103. Obviously, you're dealing with a condition where you did the lymph node biopsy, you saw hyalinized blood vessels and a diffuse involvement by small lymphocyte cells, which are CD20 positive. And we gave this as a mantle cell lymphoma blastic phase. Now remember, for the blastic phase, it is a morphology which you see in the lymph node. Blastic phase is not diagnosed by flow. Flow gives you the leukemic phase of mantle cell lymphoma. Case 4, a 60-year-old male presented in the OPD with complaints of weakness, fatigability, and a one big episode of fever of 2 months duration with no history of bleeding, bone pains, or abdominal discomfort. These are the labs, 19,400 count with the 89% lymphocyte, and they were large atypical lymphoid cells, few showing polar villus projection. So this was the peripheral smear showing polar villus projection. This was the bone marrow aspirate, where the inset shows the cells with polar villus projection and a large clumped nucleus. So SMZL, hairy cell leukemia variant, and hairy cell leukemia were all considered. This was the flow. The FMC7 was strongly positive. So was CD79B and a CD20. The CD11C was negative. 25 was weakly positive. And 19 was positive. 103 was negative. 2 and 3 were negative. 23 and 5 were negative. These were the positives. FMC7 was positive with a 19, 20, and a 79B with a 200 positive and a 25 positive. Negatives were 10, 23, 2, 3, 11C, 103, and 5. So 1 point is given to the expression of each of the 4 markers of 11C, 103, 25, and 123. And a score of 3 or 4 is observed in 98% of cases of hairy cell leukemia. Here, the score is less than 0 or 1, so it is hairy cell-like disorders. Immunophenotype, we saw CD25 is seen positive in 25% of SMZL. Most textbooks say the CD25 is negative, but we have seen 25% of SMZL shows CD25 positives. Such cases present with high lymphocytosis and diffuse involvement, particularly if they are CD5 positive. Importantly, SMZL lacks all recurrent chromosomal translocation, unlike other CLPDs. 30% may show NOTCH2 and almost 40% KLF2. So this was a case of SMZL. Other DDs to include, so exclude CLL, do a LF1 in the IHC, exclude mantle cell, do a cyclin D1, exclude hairy cell, do a annexin A1, and exclude follicular lymphoma, do a CD10 and a BCL6. Case 5, a 81-year-old man was evaluated for leukocytosis with 90% atypical lymphocytes and mild thrombocytopenia. The atypical lymphocytes were large, round, oval nuclei, condensed chromatin, prominent nucleolus, and a blue-gray cytoplasm with scattered hairy projection. The flow showed 19 positive, 11C positive, 103 positive, 25 negative. What are we dealing with? A variant hairy cell, which is now no longer entity. It is called a splenic lymphoma with a prominent nucleoli in the WHO 2022. An entity that is biologically distinct, we always knew it was distinct from hairy cell. Morphological features are intermediate between hairy cells and pro-lymphocytes. So we used to wonder whether this is a family of pro-lymphocytes or maybe a family of the leukemic phase of mantle cell. We always knew this. So this has finally come in the WHO 22 classification. Unlike the hairy cell classical, the variant has a prominent nucleoli and less marrow infiltration. There is extreme leukocytosis, unlike hairy cell leukemia classical, which presents with pancytopenia, monocytopenia, neutropenia. Both express 20, 22, 11C, and 103. However, CD25 is bright in hairy cell and not expressed in variant hairy cell. 123 is bright in hairy cell. And most important is BRAF mutation B600E, which we have now in the IHC, as well as annexin A1, both of which will be negative in a variant hairy cell. A sixth case, a 52-year-old male with B symptoms with a huge spleen, rapidly rising TLC, and this was foxing. We all thought that these were some sort of blasts in the peripheral smear and the bone marrow. Huge cells, angry-looking cells, anaplastic cells, prominent nuclei, numerous large lymphoid cells in the peripheral blood with distinct nucleoli, and we were foxed. So this was a case of BPLL. Leukocytosis is more than 55%. Now this is no longer an entity, as I told you earlier. With circulating white cells are pro-lymphocytes. The bone marrow, if you see, is infiltrated in an interstitial or nodular pattern, unlike the diffuse pattern of hairy cell. These cells express bright surface IgM plus IgD and a bright CD20, as well as other pan-B cell antigens like 19, 22, 79. 5 and 23 expression is weak. 11C, 103, 10, 25, and cyclin D1 are not expressed. They do not express annexin A1. So these are the few diagrams which differentiates a BPLL from a hairy cell leukemia. This entity can be seen either as a transformation of CLL, which is not agreed to by the WHO 22 classification. When a de novo disease, and that is what BPL is all about, blastoid transformation of a mantle cell lymphoma is a must consideration, and therefore you must do an underlying translocation 11-14 to exclude it before considering a diagnosis of BPL. The SDRPL lymphoma, this is a new entity which shows diffuse infiltration of bone marrow and peripheral blood. Here, the bone marrow will show pure intrasinusoidal bone marrow infiltration with CD20 positive and DBA44 positive cells. So these are some of the differences between SMZL, SDPRL, and hairy cell. SDPRL is the only one which will show intrasinusoidal lymphoma cells, which are CD20 positive and DBA44, that is CD72 positive. And these are some of the scoring systems used for SDRPL versus SMZL, which is beyond the scope of this particular talk. And of course, the CD200 and ratio with 180 median fluorescent intensity has also been used to distinguish SDRPL from SMZL. A classical hairy cell leukemia, we will not go into the details of this. This shows all the structures positive, 103, 25, 11C, etc. The ninth case is an interesting case of a mass in a 26-year-old female with the left and right hypochondrium of 2 months duration, with fever and epistaxis. Liver was 7 centimeters, spleen was 20 centimeters, massive spleen, young female, 26. This was the TLC, 13,400, atypical lymphocytes, 64. Look at the cells, they're all looking like blasts. Normocytic normochromic RBCs, large atypical lymphoid cells are seen. This was the bone marrow aspirate with a differentiation of ALL, hepatosplenic lymphoma, splenic marginal lymphoma, and TLGL. Irregular nuclear contours, prominent nuclei, MPO, NSC negative, pale cytoplasm, and large atypical lymphocyte. This was the flow. The 19 and 34 was negative, 5 and 19 was negative. CD3 was positive, TTT was negative, surface CD3 was strongly positive. 4 and 8 negative, TCR gamma delta positive, alpha beta negative, surface CD3 positive, 56 negative, 64 11C negative, HLA DR MPO negative. So what are we dealing with? We are dealing with a bone marrow which was infiltrated with a monomorphic population of lymphoid neoplastic cells with intracytol CD3 positive cells highlighting the lymphoid cells within the sinusoids in the bone marrow. And this was a case of hepatosplenic T-cell lymphoma, and you can differentiate it from a TALL in case you have a doubt that you are dealing with acute lymphoblastic leukemia, where the lymphocyte TLC will be very high with acid phosphatase positive and a CD34 and a TD positive. The last two cases, a 60-year-old lady presented with high fever, night sweat, skin rash, and autoimmune hemolytic anemia with generalized lymphadenopathy. A lymph node biopsy from inguinal node done and also subjected to flow. Look at this. Partial or total effacement of the total architecture with small lymphocytes having clear to pale cytoplasm, with vascularity which is very prominent with arborization of the high endothelial venules in the paracortex. The PAS stain highlights the high endothelial venules. This was angioimmunoblastic T-cell lymphoma. Here you have to demonstrate at least 2 T follicular helper T-cell lymphoma along with surface CD3 to diagnose ATL. So positive for pan T-cell markers 2, 3, 5, majority are positive for 4. T follicular helper cells, a minimum of 2 markers have to be positive. You got ICOS, you got BCL6, PD1, that is CD279, 10, and a CXCL1. FDC framework is markedly positive with the 21, 23, and 35 markers. And the Epstein-Barr virus is positive in the large immunoblast, which was shown in the IHC. This is a 76-year-old woman who presented with pallor and fatigue and had a leukocyte count of 6.5, independence of 9 per liter, and anemia. Look at the peripheral smear. Medium to large atypical lymphoid cells with hairy and shredded cytoplasmic projections. Dispersed chromatin, prominent nucleoli resembling variant hairy cell leukemia. But what did we get? Site scatter 19 gated cell scatter lacked expression of 11C, 23, 103, and 123. So variant hairy cell leukemia was out. It expressed strong CD38, 138, and 56 co-expressed and a lambda light chain restriction, so a plasma cell dysplasia. The serum protein electrophoresis and immunofluorescence further proved an M spike with the IgG lambda the overall features were consistent with plasma cell leukemia. So a plasma cell leukemia in the peripheral blood can mimic a hairy cell and a hairy cell variant. And these are various conditions where you can highlight the morphology and the immunophenotype. A follicular lymphoma case is now depicted in an elderly male with sweats and weight loss. This was the lymph node which we crushed and did the flow also. This is the neoplastic follicles with poorly delineated and attenuated and absent mantle zones. This was the high power view showing centrocytes and centroblast. And in the flow, we got a strong CD45 with a 1910 co-expression, a kappa restriction. A cytoplasmic BCL2 has now been standardized in the lab, and that is strongly positive. So overall, it was lambda restricted and not kappa, and 20 positive. So surface immunoglobulin is usually positive. B cell associated antigens are positive like 19, 20, 22, and CEP10A. Positive for cytoplasmic BCL2, BCL6L10, negative for 5 and 43. So ladies and gentlemen, the take home message. Multicolor flow cytometry has its advantages, but remember with humbleness its limitations. Always communicate with clinicians and colleagues in pathology, cytogenetics, and molecular fields. The lymphoma leukemia spills can be reported immediately and can save lives, such as we did in mantle cell lymphoma leukemia spill, and of course cases of Burkitt's. Strict quality control measures are of paramount importance in the flow cytometry map. I acknowledge my team in Army Hospital RR, Colonel Ankur Ahuja, Colonel KJ Singh, and Colonel Venkatesan, all of whom have done DM in AIMS or have done their training at AIMS and are doing very well in the national field. And of course, to the last lady, Dr. Shilpi Moore, who is a trained hematopathologist from Tata Memorial Hospital, Bombay, and who works with me and helps me out in all the hematology aspects in this hospital where I'm presently employed. Thank you, ladies and gentlemen. Jai Hind.
Thank you, Dr. Chatterjee, for your fantastic presentation. And the most important is last 11 that case capsules, which is really excellent. So I request the panelists, just please use the raise hand sign. I will pick up the question one by one. Please ask one question at a time because there are so many panelists and everyone should get a chance to ask their question. So Dr. Amrita, please go ahead.
Opportunity. It was a wonderful webinar, and I think Dr. Chatterjee has covered it beautifully. Whatever must be the message for our fellows, for all the hematopathologists. So I'll like to ask 2 questions and would like to make 2 comments. So the first question is like, so how do you establish a diagnosis of TDD positive high-grade lymphoma where there is a triple hit gene rearrangement present, like it has got MYC, BCL2 and BCL6. So how do you deal with this diagnostic challenge?
So that's a good question. And as you have seen in my presentation of CLPD and mature lymphomas, the flow has got limitation in the diagnosis of high-grade lymphomas. So let's be very clear that the limitation has to be understood. High-grade lymphomas, I would rather see the lymph node biopsy. I would like to do the IHC, and I would like to use the break-apart probes for the BCL2 and the BCL6 and the MYC, particularly the MYC and its translocation. So for me, high-grade lymphomas can be, you can establish the clonality as I showed you in some of my slides. You can establish clonality. You can differentiate it from an acute lymphoblastic lymphoma. But for a high-grade lymphoma, I will stick to the good old lymph node morphology, IHC, and use the break-apart tools for my FISH diagnosis.
Thank you.
Thank you, sir.
Dr. Dasgupta.
Yes, Tathagato, first, congratulations for a very exhaustive and highly informative presentation on a very difficult and complex topic, which, as we all know, is still evolving, thanks to the new classifications that have come up recently. You mentioned about the WHO classification or WHO recommendations or guidelines which have been proposed recently, but there is another one to complicate the scenario, which is the International Consensus Committee or Group classification. And there, and I believe this is, as I said, a work in evolution, work in progress, and therefore, accepting one or the other recommendation gets a little difficult, because there are similarities between these two sets of recommendations as well as differences. So I think we, as hematopathologists, need to be a little more careful and wait for the dust to settle down, and then adapt one or the other, or give whichever classification one believes is the right way to go ahead. So that was my comment about word of caution maybe for the younger generation, and also for the clinicians in the the group here. There are two other points just wanted to mention. One, that you mentioned about the role of CD49D in prognostication of CLL. Our experience with this particular marker has not been that encouraging, because we have been using this for some time, and we do not see any kind of the kind of correlation that the literature mentions. So I think one has to be maybe review these things as we do in course of our endeavor to reach the right kind of panel. And the second comment would be on the MBL, as you did mention that there is now a new entity where we are talking about diagnosis of MBL when the count is extremely low, less than 500 white lymphocyte count, B lymphocyte count. I wonder if this is splitting the hair a bit too much. Again, this brings us back to the point I made earlier about the WHO and the ICC recommendations. I think we need to wait and see how these areas evolve before we adapt or accept these recommendations. And finally, I just thought for the younger generation, when we are talking about immunophenotyping of CLPDs in particular, there is so much information that it makes a lot of sense to prepare some kind of a chart, wherein something on the lines of what Craig and Foon published about a decade back, wherein you list the entities as per their marker expression. Like, for example, Tathagat did mention about the B lymphoproliferative disorders, which are CD5 positive and CD5 negative, versus CD10 positive and CD10 negative, and follow a flow of logic in reaching a diagnosis. Similarly, for the T lymphomas, to follow CD4 positive, CD8 negative, both positive, both negative, and vice versa. So I think this kind of an approach for the benefit of the younger entrants in the field will be very useful. And in fact, many of us follow that, because although even though the the recommendations or the newer informations are coming up, I think those can be incorporated on the basic backbone of this kind of tabular accounting of the various entities, and that definitely will help us reach a diagnosis quickly.
That's a very, very good observation, and thank you for so much of wisdom, because you have been the architect of flow for such a long time, and we have been following in your footsteps. So the algorithm is what Sir has said, and that algorithm has to be followed, and the protocols in the flow are so rigorous and so strict. So just going to the flow and just seeing a marker study is not the answer. So it has to be a very, very scientific approach and strict implementation of your protocols following an algorithm. Coming to the low count MBL, which I had diagnosed in 2009 as a non-CLL type of MBL. So basically the WHO 2022 is now rephrasing it as a low count MBL. I'm still waiting for my boy to convert to CLL. He has not. It's been 15 years and he's got a kappa restriction and he's doing well.
Yeah, and Tathagato, and for all of us, we need to take note of the fact that as we grow old, these clonal hemopathies are going to bother us. with the age of the population increasing. So we will be coming across this kind of entities, and that is now recognized, of course, in the lymphoproliferative disorders, including myeloma, kind of scenario, as well as myeloid leukemias, acute pre-leukemic conditions. So I think this is a very good point you have mentioned, and I think this awareness is very important for all of us.
That clone of MPL, which I said in the old age, that should not be overdiagnosed as CLL. Correct.
Yeah, right.
Thank you, sir. Dr. Aditi?
Thank you, sir. My question is, how do we suspect and diagnose a CD5 negative mantle cell leukemia?
CD5 negative mantle cell lymphoma?
Yes, sir.
CD5 negative?
So rarely...
so we'll keep, okay, rare is rare, agreed.
Yes,
but this topic is for everyone. So a mantle cell lymphoma conventionally is a CD5 positive, CD23 negative. Suppose you are still suspecting mantle cell lymphoma, maybe you have seen the morphology and you are doing it, then go for cyclin D1.
Okay.
So the rare cases of CD5 negative, rare is rare, but if it is rare and you still think it is mantle cell and you have excluded SMZL and all the other five negative CLPDs, then go for a cyclin D1. So keep it simple.
Okay, sir. Thank you. And sir, why is there variable CD20 expression in different mature B-cell lymphomas?
Yes, that's a very important question. This is what we see. For example, when you say CD20 and CD79B, and you say they are strong in CLL, you are not dealing with CLL. CD20 will be weak, CD79 will be weak. So this percentage of expression and intensity of expression, as Dr. Rajgupta used to teach us long time back, both have to be taken into context. So when you see an expression which is very bright of CD79B, you are maybe dealing with the atypicals, not at all you are dealing with CLL. So you have to be very careful. So the variability of expression in CLPD is a must. One has to standardize this expression in your flow lab. So the bright expressions will be in the CD5 negative. So hairy cell leukemia, SMZLs will have bright CD20, bright CD79B. But when you come down to the CLL part, it will be absolutely dim. So you got to be very careful.
And incidentally, expression of CD20 is linked also to FMC7 expression.
Yes.
And that's why you will see that in the entities where you have bright CD20 expression, there is also FMC7 expression. So they go hand in hand because they're structurally related.
In fact, in the earlier days, Dr. Dasgupta used to tell us an FMC7 positivity. FMC7 positivity negates the CLL. We used to have those 1-1 liners. FMC7 positivity negates the CLL. That's how teaching was in the earlier days.
Things are changing, of course.
Thank you, Dr. Aditi. Dr. Sindhura. Please, my request is one question at a time.
Yes, sir. Thank you very much, sir. It was a brilliant talk. So my question is, when we do a flow on staging marrows, mainly we get flow requests when we do staging marrows to detect the low level of infiltration. So what would be the cutoff, sir? Because sometimes even when we see abnormal cells morphologically, because of hemodilution or processing, the percentage of abnormal cells in the marrow would be less. So would you still call it, say, for example, if it is less than 1%, but definitely there disease as bone marrow involvement, or would you refer to the morphology alone?
So this is where Dr. Gayatri will also tell you that there is a limitation. I've been always telling you, understand the limitations of flow. When you do staging marrows in NHL and you're looking for B-cell infiltration, there is no doubt you're going to do morphology. You're going to do bone marrow biopsy. You will see the infiltration of the small B cells. You will see the interstitial pattern or nodular pattern. These things are not seen in flow. So by just seeing a few clonal cells and saying that, yes, this is MRD positive or whatever, we have got various guidelines for MRD. But for staging marrows, when you're actually seeing the improvement or the staging, I would rather see for B cell infiltration, go for biopsy, go for morphology, do the IHC. Flow is an adjunct to these policies. So add on to the flow, but flow independent, no.
Thank you, sir.
Dr. Gayatri? Madam, we are muted.
Yeah. A brilliant talk for such an exhaustive topic. I think it's very difficult to do justice to million aspects of this topic, and I think I really enjoyed getting an overview. Thank you. My question is a little bit related to what Dr. Sindhura mentioned and what your explanation was. In the current situation where there is a standard practice of sending samples to referral laboratories. Dr. Dasgupta is on board, so I specifically would ask his observations also. In this current practice, where directly the sample goes from the clinician's bedside examination to the referral lab, we have, to my mind, we are missing a lot of links because it is easy to send a peripheral blood sample or maybe a marrow sample. The rest of the material that is so vital to evaluation of LPDs is, there is a black hole there. These are missing. So I'm wondering how these labs tackle this problem. In your, even your case presentations, you are able to tell that a clue lies in a tissue evaluation. And when we are doing only flow of one particular sample that has reached, how do we evolve reporting protocols? And how do we make sure that that missing clue is highlighted in the report?
I'll ask Dr. Dasgupta, since he's in charge of a central lab, because I work in an institution in a vertical setup where everything comes, and I actually, we have a clinical and a pathology team. I do the ward rounds myself with my clinicians and pathologists. And we are a team which we feel we speak the same language without any ego. But in a reference lab where Dr. Dasgupta works, and suppose I'm sending him a sample or someone else's sample, I think Dr. Dasgupta's words of wisdom would be most appreciated now, sir.
You can probably afford to withhold your report until your clinician gives you the sample that you desire. He probably listens to your opinion and says, okay, we will wait until you are able to conclude. And you have access to IHC also. Now,
so very valid point, Dr. Gayatri, and really appreciate your raising this. This is a fact that, if you are doing this, only flow cytometry in isolation, you'll have a problem. You will report what you find or what you see. That doesn't necessarily, give you the total picture. But by and large, in places where I have practiced, I have insisted on also the bone marrow aspirate and biopsy to accompany the flow, sample. But biopsies sometimes are not available, but aspirates are usually available in case there's a marrow which has been sent or marrow has been done. So that's a prerequisite, that's a must that you should have or insist on when you are doing a flow cytometry. At least you are a little better off. In some of the labs, or currently as I work, or even earlier, I do the HemePath or the bone marrow biopsy reporting as well. So I think in most of the cases where I've got the flow, I've also got the biopsy sample. The advantage of flow is that the flow data and the aspirate are ready. The report of the aspirate are ready very quickly, while biopsy takes a little while. It's a little longer. And the clinician on the other side is very impatient to know what is going on. In this competitive world where TAT is very, very important, clinicians also do not appreciate holding up of the flow data or the marrow aspirate report beyond a point, because they also have to manage the patient. So we will not hold the, these two things pending the biopsy report, which I will see, and if necessary, we'll even do an IHC. So the organization which is reporting flow should do all the three things, that is flow cytometry, of course, peripheral blood examination, bone marrow aspiration, and a smear examination, and a biopsy reporting. So when you do all the three, I don't think there is any gap that way. You do the best that is possible for one to do. But I agree that there can be some labs which are only doing flow and not getting access to the, the other material. There can be gaps. But at the end of the day, I think what we talk about comprehensive reporting as a concept in hemopath reporting, some point in time, the clinician, the pathologist who has done the flow, as well as if at all separately the biopsy has been reported, they need to connect and sort out if there are any doubts, because in most of the cases the diagnosis will be there even by flow and aspirate examination. You have got a full-blown acute leukemia, CLPD. If the cells are good enough and are there in good numbers, you get a diagnosis. It's not that you don't get a diagnosis. In worst case scenario, you can even give a differential diagnosis pending the histopathology report. So I think we have a way to sort these out, and the concern is definitely genuine, but there are ways of doing that, because please appreciate, and it's for the entire team which is on this call today, that all these investigations are not readily available everywhere. And therefore, outsourcing of samples or sending samples to the central lab is a necessity. It is not something which is just done by the the clinicians just for the sake of it. So I think we have to accept that and find a way to do the best under the circumstances. And just a related point I thought will be also of importance to all of us is that aging of sample in transit is something which is of concern. But believe me, as long as the viability is not too poor to that extent where you have, when you run the flow, you have all kinds of, haywire kind of a report. By and large, you will be able to make a diagnosis, even if the viability is low, is not 100%. And that's very important. And in fact, there are several of these lymphomas, like high-grade lymphomas particularly, somebody mentioned that. You will see that when you look at the smear made from the sample, you will get to see a lot of apoptotic and dead cells. But when you run the sample, you will see that you get a very reliable data. So to say that just because the sample is old, I will not run the assay is also not correct, because it's a fait accompli. You have already collected the marrow. It's a traumatic procedure for the patient. So you should not be rejecting. You should try and do it and make a sense out of whatever you've got. So I think this is a message I would like to convey from my own experience of working for decades in these kind of central labs. And I think it happens, like loss of CD38 or 138 in myelomas. It does happen, but then there are other markers which will help you make a diagnosis along with the other parameters. So I think this is the challenge of diagnosis. You see, if we have got a straightforward, nice, tailor-made case, that doesn't give you so much satisfaction as if you resolve a problem, a case riddled with problems.
I think, sir,
I hope I have answered.
Yeah. Sir, I think I just comment one thing, because I'm basically a pathologist and then I switched to clinical hematology. So, sir, most important thing is that comprehensive hemopath reporting is the only way to go forward. Starting from the peripheral smear morphology to bone marrow aspirate morphology, bone marrow biopsy, and the flow. These all four should be integrated.
Yes.
And I always tell my juniors, you can send any reference lab, whatever you're comfortable, but try to make an arrangement that all four people are sitting in one place, so that they can talk each other and you can also talk to them. That is the only way.
Send all the four samples.
Yeah,
all the four samples, because clinicians don't necessarily send all the samples to one person. They have choice. They'll send histopath to somebody, the flow to somebody else, look at the marrow themselves. So all kinds of things happen. So this is also a fact. And one more thing I've seen, so now there are many junior hematologists who are very much cost sensitive, but you need to do all these things. Otherwise, you can't provide diagnosis. Or unless or until you have a diagnosis, you don't know what to do with that. You start something, then after 2 cycles, you don't know what to do. Then again, everything becomes mess. Then the patient anyway run for second opinion, third opinion, all these things happen. I think my message to you, that very comprehensive thing, go a good physical exam. If you see the peripheral smear and bone marrow aspirate on yourself, it's a fantastic thing.
that I do always with my patients. And then you talk with the pathologist, hematopathologist who is doing the biopsy reporting and the flow, and take your confidence, share the data, and only reporting. I always tell the people, don't rush for reporting, take your time, because I understand that you can't make a block of the histopathology block in 1 hour time, right? So you have some time to give to the pathologist also to work properly. That is the way things will move. I think it is a very
because you are right.
Very nice.
Because you come, you have a background of pathology, so you understand the pains of the pathologist. But many of our clinical colleagues don't. So
I agree, sir. I agree.
What I do in FMC and Army Hospital RR and various other hospitals, the pathologists take ward rounds. Now let's be very clear of it. We are first physicians, then we are respective MDs in whatever subject we have done. So if a pathologist tells me ki history mere paas aaya nahi, I'm waiting for history for 48 hours, I mean, that is not acceptable. Go to the patient, see the patient. I'll tell you a case, 2009, rapidly increasing lymph node in a child. And, the peripheral smear was L3. I mean, what more do you want? You can't withhold report like that. Go and see the patient. We did a flow, TDT negative, 34 negative, 20 positive. So you have to give this report, as Dr. Sanyal has said. This is a life and death. You have to start the hyper CVAT regime of buckets and, save the child. So the pathologist has to do ward rounds. We are clinicians first. And that is what Armed Forces has taught us. And that is what I'm practicing in my retirement life also.
I agree,
so we take our ward rounds.
And one more thing is very important, sir. When I request all my younger hematologists that whenever you send a flow sample to the flowcytometrist, please provide it at least one peripheral smear and one bone marrow aspirate smear to them.
Yes.
Otherwise, only isolated reporting flow, causing much confusion. Even I told many times, Dr. Rajgupta may remember, that please don't send the report to us. Wait for the bone marrow aspirate report to come, then we report. And I always give a standing instruction to my flow cytometrists, don't release the report. Most of the time, CLPD is not emergency. Most of the time. So we can wait for a day or two for a good comprehensive report to come. I think the next question, Dr. Akshaya, you can just go ahead.
Thank you, sir, for a brilliant talk. All my doubts have been actually cleared very beautifully in the lecture. Thank you so much for that. So there's one problem we are facing. Sir, in morphology, especially in cases of plasma cell myeloma, we are getting around a good percentage of plasma cell, but at the same time, when we are doing diagnostic flow, we are having a significant amount of cell loss. So how can we just...
That is a problem I showed you in my slide. That is a problem in flow in plasma cell myeloma. Unlike morphology in IC, where we got much more yield of plasma cells, in flow, we lose out on the plasma cells. So that is a limitation of flow in plasma cell myeloma.
That's an universal experience. And that happens because the plasma cells tend to stick to the particles, the fat globules, and that is when you lose them in the sample when you are trying to take out the, prepare the cell suspension.
So this is a problem in flow.
Dr. Naveen?
Yes, sir. So Dr. Gayatri actually stole my question. So that has been actually addressed. However, one comment and a question to Dr. Tathagat. This is regarding adding more lasers and colors and more antibodies in one panel. So does this cause a confusion and overlap in spite of the compensation that happens? And does it cause diagnostic problems?
So it does. Actually, it does. So, way back in 2009, when we started with a 4-color Beckman, it was answering many of our questions. But the concept of MRD came up much later. So, for MRDs, you need more colors, more dot plots, more significance. So, like in a 10-color, you have a 45 dot plot versus a 4-color where you got just about 8 dot plots. So that much of answering simultaneously looking at all the antibodies, because you're using the gating strategy in all the tubes. So it does answer. But then, people do get carried away by colors. That is not the answer. So you need minimum color panel. 4 color is good enough. But when you're doing MRDs, then you need that much, that lesser tissue to answer more questions. Right. So if you have set up your flow cytometry lab correctly with all stringent guidelines, I think 10 color is the ultimate answer for all your MRD problems. A 6 and 8 color does answer those questions, but the MRD in a 4 color is difficult.
I would like to add here, Tathagato, you trained under Dario Campana.
Yes.
And if you look at the BALL MRD data from St. Jude's, they are all based on 4-color analysis.
Yes.
So it is not the colors which matter.
It is not really the color.
Use of combination of antibodies.
Yes,
The
yes.
plots are which are important for picking up the abnormal populations. Those are important. That combination of 2 antibodies or 4 antibodies or whatever is important. And
Long time back,
more colors you
yes.
get into, you'll have other technical problems. So I think
There are
86 colors is good enough for current use. And I think that is what most of the labs are using.
St. Jude's in the earlier days were doing MRD light. Actually, if you remember, they all started with MRD light program using just 4 antibodies. But gradually they matured because the clinicians and the prognostications and the demands were so much. So the colors progressively increased. So they actually originally started Ellen Houston Smith with a 4 color. But with time, we are increasing.
Madam, Dr. Manchanda, please. Madam, you're muted.
Mute. No.
Madam,
can you hear me now?
Yeah.
Yes.
Yeah, okay, good to see all of you. Brigadier Chatterjee, so nice, Tathagat, to see you and everybody else. My very simple question, we have now shifting from a 4 color to, 6 color to 10 color. Any advice on that? We are struggling. We are just a year into a flow cytometry, and we have just got used to it. But now the company is saying switch to 10 color. Do you think it's advisable at this stage, or should we wait?
Okay, so that's a great question because we have just established a year back our 10 color here also. So maybe the same company is speaking to you and to us.
It looks like it.
But what we did, ma'am, was that, from day one, we are sitting with their clinical scientists, or their clinical specialists, as you call it, the technical know-how. We are sitting day and night with them because it is a technical subject. And it has taken us real time to standardize this flow, but we took the challenge. And it is giving us a lot of dividends. Now, I will not go on because after 3 years, they'll come with 14 colors. So I do not know what that is. So there is no end to it. As Dr. Naveen said, a lot of confusion. But so far, we have standardized. And whenever we have problems, we are with them. They come to us and they help us standardize and answer a lot of issues. So
you think it's an advantage? It's an advantage over them.
Not only in diagnosis, but ma'am, today, everywhere you have to give the MRDs. And that much of samples, you want that much of events. You want 3 lakh events, 4 lakh events. And answering from a minimal sample, the questions of MRD. Because the treatment, the prognostication and the management completely changes with the MRD. So with that in mind, so diagnosis, so we will give. But the MRT issues comes with more colors because that much less sample is giving us that much more answers.
What about the cost? Before, we haven't started MRD as yet.
No, the cost is sustainable once you have the instrument and you have your know-how that these are your monthly maintenance figures. That means you calculate, okay, these are the number of cases you're going to come. You can have a budget. You can have a budget, but you have to maintain your budget. Like an accountant, you have to maintain your monthly measure. These are the reagents I need. So you need a stock balance. What is expended, expense balance, stock balance. You have to be a manager because the reagents are the antibodies are very costly.
Expensive, very costly. One more question. Have you tried lymph nodes for lymphoma?
Yes. So that's what I was trying. In 2019, we did a workshop in Army Hospital RR when I was heading the department. So we have to literally dismantle the lymph nodes. We use papain enzymes, we use DNAs, we use EDTA, and that helps us in making a single suspension with an acceptable sorter speed. So that sorter speed is anything between 2,000 to 20,000 cells per second. So we have been very successful, particularly in Burkitt's lymphoma. We trust the lymph nodes and we gave the diagnosis there and then. TDT negative, 20 positive, CD34 negative. The lymph node architecture we have not yet seen. The peripheral smear we have seen, and we could give buckets. So lymph node is there to stay. Pleural fluid is there to stay. And as long as your tissue, your processing in the lab is correctly made, this is the future. This is the future.
Okay. Good, great.
Dr. Manchanda, just to answer your previous question, which was about
Yes,
costing
please.
and all.
Yes,
I will just suggest to you for the BALL MRD, which is the
Yeah.
starting point in most of the labs.
Yes.
Your first tube, which is the B tube, you can
Yeah.
make it in a way, whether it's 8 color or 10 color, which you can apply for diagnosis as well as for MRD.
Okay.
You have to really juggle with the composition of the that tube.
So if you got
Okay.
if you got your diagnostic panel, then you can compare it with your MRD panel.
MRD. Also,
MRD
that is
panel.
the we have
Oh,
done the diagnosis at presentation. I mean the immunophenotyping at presentation. Then you can follow up much better, and it saves you money because you're not going to have another set of panel for the MRD.
Exactly. Thank you.
I
Thank
think
you
the
so
same
much.
question will come, that we should send always that the diagnosis and then date, blast, and then the post-induction MRD in a single place and by a single person who is to do all three together. I think that is very important. Dr. Amrita, I think, yeah, we are almost closing the session. Dr. Amrita, please go ahead with your questions. There are no more hands I'm seeing.
Thank you, sir. Actually, I just wanted to make few comments. One is about ma'am's question, and sir responded it very well. But what my experience is like, as far as we talk about flow cytometry on lymph node tissue, I think not all the time it is possible to give a correct diagnosis on the lymph node flow. We should have both the histopathology of the lymph
Absolutely.
node
Obviously.
and the flow.
Yeah, yeah.
Obvious.
Yeah, yeah.
Absolutely.
So-
No
Obvious.
doubt on that. There is no
Yeah.
doubt on that. Morphology
Yeah,
can
yeah.
never be replaced
Yes,
by
yes.
flow cytometry.
Yeah.
Okay.
Yes.
Morphology
That
and
is-
of course IHC. Okay. Flow cytometry is a supplementary aid to
Yes,
you.
sir.
But if you're
Yes.
thinking of flow, that I'm a flow cytometrist and I'm not going to see the lymph node architecture, you are an escapist
Oh,
pathologist. You are
Yes, sir.
escaping from morphology. That is wrong. Your basic thing is morphology, morphology, morphology. If you're not doing morphology, you're doing flow, you are an escapist, poor pathologist.
No.
Yes, sir. So because of my
Absolutely
training,
right.
I like your statement. Escapist pathology.
yeah. So two
Thank
more
you,
comments I
Professor.
would like to make if I am allowed.
But I'm a little brief, huh? We don't have much time in hand. And I
Yeah.
have some
One
questions.
thing,
I have to pick up from some questions from the audience also.
so one is like about these plasma cell leukemias. Recently, we have seen there is a lot of difference in the morphological presentation. Like one we thought even erythroid leukemia, one we thought CLL, and then one was, of course, we were not sure what kind of CLPD it's going to be. And finally, by flow, it came out to be primary plasma cell leukemia. And the second question for Tathagat sir is, do you have any experience on CD319 in terms of assessment of plasma cells in cases of myeloma, especially follow-up cases, which are treated with daratumumab?
So your first question, I have also shown you in the slide, hairy cell mimic. Plasma cell leukemia is one of the conditions in hairy cell mimics. I've given this presentation earlier. I showed you those cells with shredded cytoplasm and all. And the site scatter CD45. CD45 was negative. And then we did the 38, 138. So plasma cell, so that's why it's must to include a plasma cell antibody in your CLPD panel. Your
Yes,
second
sir.
question is excellent. I have got no experience on that.
Okay, sir.
So
Thank you so
there
much.
is a question from the audience.
Can I answer Dr. Sharaf's question?
Just a minute.
Yes,
Sir.
yes.
There's a question. There's a 60-year-old female presented with a generalized lymphadenopathy, splenomegaly, and total count of 33,000 with 77% lymphocytes. Peripheral smear reported as atypical lymphocytes, bar blast. Now, how to decide whether to go for CLPD panel or acute leukemia panel? So that is a question from Dr. Dhiraj.
Okay, so question is, what is the onset? Is it acute? Is it chronic? First history is that.
Yes,
How long has the patient been having? First is history. 3 months, 6 months, increasing spleen size. So we are thinking of CLPD. If it is an acute onset, the spleen generally doesn't come in an ALL or AML that quickly. However, a CD34 and a TDT can always be included in your CLPD panel if you are thinking of CLPD first. So you can differentiate a CLPD from a immature cell by a TDT and a CD34 panel. And a strongly positive surface membrane immunoglobulin is a CLPD. So first is get your history correct. Is it acute onset, chronic onset? And then make a panel, and there is no harm in adding a tube of a immature marker. If you still have a doubt, add the immature marker and finish it off.
So I remember after seeing this question that when we were a student in JIPMER and when you used to write in our notebook atypical lymphocytes bar blast, Dr. Basu used to blast me like anything.
Yes.
There can be dual terminal. You have to commit, man. You used to always say that. You have to commit.
I will tell you something about atypical lymphocyte. An atypical lymphocyte is a nightmare for a pathologist and a total confusion for a clinician. A pathologist does not know how to categorize that lymphocyte as blast or non-blast. If you read DESI correctly, an atypical lymphocyte is a benign lymphocyte and is always to be used in downy cells.
Yes, there are 3 types of reactive lymphocytes.
Yes, absolutely. The leukocyte lymphocyte, the monocytoid lymphocyte, and the reticulated lymphocyte. These are downy cells. If you have got a doubt about the lymphocyte is blast or non-blast, use abnormal lymphocyte.
Absolutely.
Why you use abnormal? Why are you feeling so shy? You say, I cannot understand this lymphocyte. Yes, we are not gods. There are sometimes we don't understand these cells. Could be blast, could be non-blast. But an atypical lymphocyte is a downy cell, is a benign lymphocyte. Use the word abnormal lymphocyte.
I think it is another example of the escapist pathologist. Yes. So thanks, Dr. Chatterjee, for a lovely presentation. Thanks all the panelists for their excellent inputs, and one of the very, very senior hematopathologists in the country. Thanks a lot for all the participants. And thanks, Kalpesh, for wonderfully managed the show and sparing all of you, sparing the Sunday morning. Thanks a lot again. And just say goodbye to all of you.
Thank you.